We have just a few more minutes. I think maybe what we'll do is sort of wrap things up with the new agents. And I'm going to ask Dr. Allan in a second about the reversible inhibitors of BTK, but maybe John Burke, you can comment on the cellular therapy and CAR-T and whether or not that represents promise for our patients with CLL.
I think at ASH we saw data on the CD19 directed CAR T cell product, Liso-cel, and they showed data on 23 patients, most of whom had failed ibrutinib, and demonstrated an overall response rate of 81% and a complete response rate of 45%, and MRD undetectable rate of 75 to 85%, depending on blood versus bone marrow. The toxicities were not trivial. 74% of patients had some degree of cytokine release syndrome, although only 2 were rated as grade 3. They saw tumor lysis syndrome in 17%, suggesting clear activity. So I think, the data remain fairly early. That particular product would certainly appear active in this high-risk population, but it's also pretty toxic. And so it's not something I have referred many patients for, and right now I save it for last. We've also seen data that CAR-T can be added to ibrutinib. So this wasn't, I think, at the last ASH, but patients who've been treated with ibrutinib for, I think it was 6 months, and failed to achieve a certain degree of remission, then had CAR-T added, and they basically showed that it sort of helped to clear the bone marrow and achieve deeper remissions, but at a fairly considerable toxicity cost and financial costs as well. So I'm a little uncertain as exactly where the final role will be right now, and I think right now it's remaining a research tool. And
in terms of newer agents in development, there's a lot of work going on now with the next generation of BTK inhibitor, the reversible inhibitors. I know, Dr. Allan, you've done some work with the reversible inhibitors. Can you highlight some of the features of those new agents? How do they differ from what we have available with the irreversible inhibitors, and what we're seeing with the activity for those compounds?
Yeah, absolutely. So, it's important to remember that the 3 big currently FDA approved in BTK inhibitors are all covalently bound to the protein BTK at the CYS481 amino acid, which is within the kinase pocket, prevents activation and phosphorylation, and basically inhibits and kills the enzyme irreversibly. And therefore, the only way for the cell to make more BTK is to transcribe it and then translate it and then repopulate the protein, which then just gets inhibited the next day when you take the new BTK inhibitor. So what we know is that seemingly the resistant mechanism around that is to develop a mutation in BTK at that CYS481 residue, and you turn it from a cysteine to a serine, and therefore that disrupts this irreversible binding and covalently binding to the protein, and therefore the molecule gets kicked out. And so that's the major mechanism of resistance that we've recognized. That in vast majority of progressors that have been reported, a BTK mutation is typically present. And so these current covalently bound molecules have short half-lives. Therefore, the drug is in and out of the pocket, then gets washed out of the system based on its pharmacokinetics. And therefore, the enzyme is then able to fire again, and therefore the CLL able to signal through the B-cell receptor. So one way that has been able has been devised to overcome that is to use what's called a reversible BTK inhibitor, to where the drug does no longer bind into the pocket irreversibly, but it goes in, interacts with the pocket, inhibits activation, and is constantly throughout the time and throughout the day is going in and out of the pocket within that cell. The PK is a little bit better. These molecules have longer pharmacokinetics. They're hanging around in the body, therefore they're staying in the cell longer, they're not getting broken down. And therefore you can actually, by having a reversible inhibitor, have relatively prolonged inhibition of the protein and have, high occupancy rate, even though the drug is not covalently bound. And so what we've seen, and there's three currently in pretty advancing in clinical stage. There's four. There's at least another one or several others that are kind of coming on board and trying to get into the clinic now. But what we've seen, and the current studies are entering into phase 2 populations and they're emerging from their phase 1 data. Limited data has really been demonstrated. These patients that are being are recommended for it are very high risk. They have BTK mutations, most are 17p deletion. And so it's a really difficult patient population to treat. And so it's hard to glean efficacy necessarily from this specific patient population. But what we have found is that these inhibitors do have activity. And what's important is that they have different selectivity for their kinome. Some are rather specific, much like acalabrutinib and zanubrutinib, and don't have a lot of other off-target inhibition. Others have similar kinase inhibition, such as ibrutinib. And then there's other molecules that are out there that have a broader inhibition of other molecules. And so we're starting to tease out, is it all dependent on BTK inhibition, or is it some other off-target effect based on these different molecules? And we're starting to learn and start to see activity. And so as we start to expand in these phase 2 populations, that's where we're going to really glean from our efficacy. We're going to get less pretreated patients. And it remains unclear to me if these drugs will be kind of in a niche to where we're really going to be using them for BTK progressors and BTK mutated patients only, or if they will be able to kind of make the jump and potentially unseat covalently bound BTK inhibitors. It's possible that you may be able to prevent the mutation by using these, because that evolutionary pressure isn't there. That remains to be seen. What has been reported is that these drugs do appear safe. They don't appear to have huge rates of atrial fibrillation. They don't have huge rates of other toxicities that we sometimes attribute to our covalently bound BTK inhibitors, arthralgias and diarrhea and things like that. And so we're learning it here, and we're starting to target our resistant mechanisms. And basically that's where we are in the current state. We'll see at ASH, I think, the big 3 companies that have a molecule that are in advanced stages showing, more results with larger patient populations, and start to really glean if there's differences between the molecules. We don't quite understand that yet. We don't quite know if there's a winner of the 3 that are currently far ahead, but we'll start to understand and start to see these toxicities and make sure that these patient populations are similar, and then try to glean why is one better. Is it potency issue? Is it a patient population issue? Is it what patient factor might predict response, or is it some other off-target effect that, as the science catches up, we'll start to learn. So we're using these drugs. They're coming around the pipe, and I do think there will be some value in them, especially in this very special resistant niche of patients. But remains to be seen how well, if they can cross this threshold to be adopted broader currently.